I would now like to introduce our meeting host, Lenore Boris, Chair of PAC Exec and Dean of College of Nursing at St. Joseph's College.
Thank you, Alexa. You all might have noticed, if you're familiar with me, that I did change positions. Welcome to our quarterly stakeholders meeting. It's the opportunity for people and organizations to come together and share ideas about how we can improve healthcare across our region. Next slide, please. Tomorrow marks a memorable day in our country's history, the 20th anniversary of 9/11. This was an event that impacted all our lives. Let us take a moment of silence to honor those who lost their lives on that day and after, and to reflect on the significance of those events. Thank you, everyone. We do have a very packed agenda, so I'd like to warn you beforehand that it's quite likely today's program will extend beyond the 12:30 ending. I hope you will be able to stay for the full presentation, because I think you will find the information presented today both timely and significant to the development of your organization. The first 45 minutes of our meeting today will be devoted to our panel discussion, the why of social care networks. I'll be moderating that discussion. Today, we have 4 distinguished panelists who I will introduce in just a moment. During the second half of our meeting, Dawn Scully will be sharing updates on the Care Compass Network Social Impact Pilot Program. Dr. Brian Justice, Medical Director of Pathway Development for Spinal Care at Excellus Blue Cross Blue Shield in Rochester, will be joining the meeting to discuss their spinal care project. Lisa Berard, a network development specialist at Care Compass Network, will speak to developments with the open network. And finally, Mark Ripecki will be sharing new information regarding the intended 1115 waiver. Before we actually get to our panel discussion, I think it's appropriate for us to just basically outline for you what is a social care network. The social care network can take many forms. It can be Care Compass Network, open network, a cohort management program, social impact pilot program, performance network, or some other form yet to be envisioned. But the idea is that a social care network addresses things like people's economic security, their food security, their housing, their transportation needs, the things that we know as social determinants of health, the things that we know impact a person's overall health. So the concept of the social care network, next slide, has several core components. These components include a group of network partners, shared language for measures and outcomes, how we measure what we're doing, shared technology platform and data integration and sharing, community planning. All of these are intended to promote cross-sector collaboration and a holistic approach to our providing healthcare to individuals. This drives system change by including both the social aspects that impact healthcare and what we historically have known as medical care. The impacts and outcomes of a social care network include such things as improvement in the health indicators, the measures by which we judge whether we're improving our health. It includes advancements in the quality of life, a focus on how to address disparities and inequities, improvements in an individual's state of wellness, and it changes our focus from the specific work we're doing to providing person-centered care. And it also requires us to change sometimes the interventions and our interactions with people. All of the idea of a social care network is built on developing trust, both between different partners who are a part of the social care network, and also between the partners and the patients they serve. And in developing that trust, and working collaboratively, we enhance the capacity to address healthcare concerns within our community. Overall, the social care network enables communities to have multi-level impacts on care, an impact on the individual's health, on the agency, on the community, and the community's health. And it does this by shifting away from a reactive approach toward a proactive, holistic, person-centered care approach to health delivery system. So with that background in mind, our panelists today are going to discuss the why of social care networks. So let me begin by introducing each of our panelist members. Our first panelist is Juliette Price, Chief Solutions Officer for Helgerson Solutions Group. Helgerson Solutions Group, at Helgerson, Juliette leads the firm's strategy and organizational development work, advising a wide variety of clients across various sectors in both policy and practice. Juliette joined HSG after nearly a decade in public sector, working to solve some of the society's most complex issues. Previously, Juliette had served as director of Albany Promise, a cross-sector collective impact partnership of over 100 organizations in New York State's capital city that focused on improving economic mobility for the city's most vulnerable families and children. The work Juliette pioneered led to new cross-sector partnerships focused on young children between healthcare and the social sector. You see why that's important as our topic today, including one of New York State's first value-based payment pilots called Connections, a value-driven project to build strong brains and the creation of the first 1,000 days. On Medicaid, a statewide commission focused on improving outcomes for children and caregivers in the first 3 years of life. Juliette was awarded the White House Champion of Change Award in 2016 from President Barack Obama for her work in this field. Juliette will be offering her insights from a managed care organization perspective. Our second panelist is Robin Kinslow-Evans, Chief Strategy Officer for Ascension New York. Robin has over 35 years of experience in leadership roles in health systems in Indiana, Illinois, and New York, working in multiple and diverse markets. She has developed depth and expertise in leading strategy development, strategic planning processes, business development, service line growth, outpatient network development, and structural preparation for value-based care and payment. She is a leader in facilitating community-level collaboration. She is one of the founding members for developing a very successful performing provider system in the New York State District program. That provider system we know as Care Compass Network. Robin has been part of the strategic planning community of Ascension Lord since 2017, serving as the Chief Strategy Officer for the Binghamton, New York Ministry Market. In this role, she has led the development of strategic plans, including the Ascension Dynamic Plan for the Ministry Market. She is also leading the development and execution of clinical integration strategy for the ministry market. Just prior to her role at Ascension, Robin served for 22 years at 2 healthcare systems in New York State, Bon Secure Health System and United Health Services. Robin will be sharing her thoughts from a health system perspective. Our third panelist is Robin Cotter, Director for Catholic Charities of Chenango County. For the past 11 years, Robin has been responsible for the executive oversight of Catholic Charities of Chenango County, an agency known for its commitment to community, innovative practices, and service to others. Robin has over 35 years of experience working as a registered nurse, school counselor, school administrator, and not-for-profit executive director. A career that encompasses the social determinants of health is one that gives her the passion to transform not only Catholic Charities of Chenango County, but all those they serve. Robin will be looking at the why from a community-based organization perspective. Our last panelist is Mark Ripecki, who you recognize as Executive Director of Care Compass Network. Since June 2016, Mr. Ripecki has served as the Executive Director and led the New York State Healthcare Transformation Initiative under the DSRIP program. Mr. Ripecki has been instrumental in convening and collaborating with hospital systems and community-based leaders throughout the largely rural 9-county region that represents 1/8 of the landmass of New York. He has overseen the development of healthcare reform, implementation, and been a catalyst for innovative funding programs that support community-led initiatives integrated with clinical services, and deployed over $135 million in resources throughout the community. So let us begin our panel discussion by calling on Robin Kinslow-Evans. Why would a health system want a social care network? Robin?
Thanks, Lenore. Sorry, I had to get off mute there. Thanks for the opportunity to share some thoughts on this. So currently, most healthcare systems have value-based agreements, and we at Lourdes have those as well. And those value-based agreements are usually constructed along payer products. So for example, Excellus has a commercial payer product. They also have a Medicaid payer product. One of the observations that we were able to make through data is there is considerable disparity between how we perform in meeting evidence-based medical quality measures with commercial populations versus Medicaid populations. And as you might expect, that performance is less for the Medicaid population. So we've long known that alone, we cannot successfully address the quality measurement performance that we're experiencing with Medicaid. And with our involvement with Care Compass Network over the last 5 years, 6 years, we have increasingly become convinced that the key to unlocking that performance problem lies with the community-based organizations. Now, one of the inhibitors in terms of getting organized and engaging with community-based organizations is simply a lack of organization. So it would be very, very difficult for us to contract individually with every community-based organization that we believe could have an impact on our ability to successfully care for our Medicaid patients. It would just be hard to organize, first of all, and even harder to administer. So from a health systems perspective, the degree to which community-based organizations can get organized into a single contracting unit and accept responsibility and some kind of structure for the administration of participation in these value-based agreements, that would be exceedingly helpful to the healthcare organizations, the health systems that are trying to and are held accountable for addressing these quality measure scores. So the why is because we need you and because the patients need you. You as community-based organizations hold the absolute trust of those individuals. You have the relationships with them. And what we've found is while we have good relationships with those we care for, they're infrequent. They are confined to a visit schedule. And that might be once or twice a year for a younger person and maybe 3 or 4 times a year if it's an older person. You as community-based organizations interact much more frequently. And as I said, I think hold the trust of the community. And I think with COVID, we were able to see the extraordinary disparities in our population. And we could also visibly see the lack of trust that different communities have in the healthcare provider system. So to my point of view, it's all about success with these populations and cohorts. And I think the CBOs are key to that and key to unlocking that. And the one thing standing in the way is a lack of organization and structure that can be relied on for accepting financial responsibility for those quality scores. And I'm going to pause there and turn back to you, Lenore.
Thank you. I'd like to move now to Robin Cotter and have her answer the same question. Why would a community-based organization want to participate in a social care network?
Great follow-up, because basically I'm going to say many of the same things that Robin said. We know that social determinants of health factors really make a huge impact in approximately 80% of health outcomes. So we are very interested for a number of reasons. Nonprofits right now are experiencing an increase in workforce shortages. We know that. We're also seeing a tremendous decrease in our donor revenues due to fatigue. And those are, the donor revenues are what fund a lot of our programs in a CBO. We have a lot of unfunded mandates, as everyone does. And also we see a lot of unnecessary duplication of services in our small communities. So social determinants is what we do and what we know. We're client-centered. So when I was asked to present today, I didn't really think about what was in it for us as a CBO. My thoughts always go to what's in it for the clients and the people that we serve. So our experience tells us that working within a network is always more beneficial in the long run for those that we serve. You know, wraparound services always work best when we focus on our areas of expertise. We as CBOs have knowledge of how this integrated community works, the referral basis, right? We already have an existing infrastructure in place, but everybody doesn't know about that. So just to give you an idea, all right, what we do, Catholic Charities is a small CBO. We only have maybe 70 employees, but listen to the things that we do. We run a community center, which deals with food insecurity issues for the entire county. We do insurance enrollment, SNAP and food stamp enrollment. We promote literacy. We have a thrift store for clothing and household items. We assist with transportation. We provide housing supports through a continuum of care model. We have expertise in working with the intellectually and developmentally disabled community through housing and community habilitation. We have contracts and work. We have expertise with the significantly mentally ill population through OMH contracts for housing, intensive case management, daily medication oversight, appointments, coordination of services. We have a care coordination model for adults and children and sliding fee counseling. Those are all in our small CBOs. And think about this huge network, as Robin was just alluding to. We as CBOs are used to working on outcomes and accountability as part of grant funding. This is what we do, right? We as a nonprofit have to work toward value-based services in order to be paid. And Robin also alluded to this, and this is near and dear to my heart. We know the community, all right? We are known by them. They trust us. We meet them where they're at. We provide them with that hand up, not a handout model. And we work with those most valuable or vulnerable, valuable to, and needy people. Okay, we are currently serving in the county about 40% of the population. How can CCN support our CBO? Through creating more value-based payment arrangements to help us to fund gaps that we have difficulty covering, helping us to fund our workforce in positions that we desperately need to collaborate and work together, and also how to help to integrate these services into the healthcare systems. So why duplicate services? We need to work together. Summarizing, I can say this: our partnership brings quality to the quantity of services currently being provided. So if we work together, we can increase our outcomes and our marketability.
Well, thank you. Juliette, maybe you can provide the perspective of a managed care organization and answer the question, why would a managed care organization want to be working with a social care network?
Sure, absolutely. And I agree with Robin that so much of what I have to say will echo the, Robin and other Robin comments. So it's great to see alignment like this. And obviously, Lenore, thanks for the very kind introduction. I'm not representing a specific plan here today, but in our work with CCN, we have been engaging in conversations with plans that do serve the members, the residents of the Southern Tier. And so we've had the opportunity to speak very specifically with them about their perspective on this topic. So we'll get into that in a second, but I would just say, to take a step back and kind of talk about it from just a 60,000 foot point of view. The role of a managed care organization has grown and will continue to grow in the last few decades. And some of the key reasons why that is obviously Medicaid and Medicare are both growing programs. And of course, in this global pandemic, we have seen growth in the Medicaid program. We will probably continue to see that growth. There will be a lot of work to make sure that folks who enrolled are not lost to care when the pandemic ends. And of course, we face an aging population here in the United States. And so folks, as they age, they of course are able to enroll in the Medicare program. For both of these sort of core businesses, we won't talk about commercial insurance today, but for both of these core businesses, the majority of the populations are moving into managed care. For the Medicaid population, which has historically been the focus of CCN, New York State is primarily a managed care state. We continue to see shifts of certain subpopulations who were sort of slower to get into managed care, very highly specialized populations such as the intellectually, developmentally disabled. That is a slower process for very specific reasons, but we see that continue and we expect to see that continue to a point where the number of people who are not in managed care will be very, very small. On the Medicare side, I say this because I think this is important, especially for this region. We do, so Medicare traditionally is a fee-for-service model, but there is a alternative, which is called Medicare Advantage, and that is a managed care version, if you will. We continue to see Medicare Advantage enrollment rise for a number of reasons we could talk about another day. But I say all that because I think the context here is, managed care organizations, they continue to grow. They continue to play an important role. You have probably seen some consolidation, not just here in New York State, but across the country. So that's another important trend to pay attention to. So all of that, kind of to give you a little perspective, at 60,000 feet, coming down to like 20,000 feet on this topic specifically about social care. In general, plans understand the importance of the social determinants of health. That is not up for debate. It's not a question. You can talk to anybody who works at these plans and they know it, they feel it, they live it, they breathe it. They face, however, a lot of challenges just in running and managing a managed care plan. And some of these, just to kind of sketch out some examples for you, enrollment is a constant challenge, right? We always say if you're a managed care plan, if you're not growing, you're dying. So they're constantly, looking for more enrollments to making sure people stay enrolled. Re-enrollments is very important. Cost containment, right? The whole idea of managed care is that it's better care. It's managed. They're able to avoid high cost events. They have to engage with their members. Just as Robin was saying, from a health systems perspective, it's the same thing from a managed care perspective. They're engaging those members. They're trying to prevent and manage through high cost events, right? Avoidable hospitalizations, very high costly things. So you have a lot. All of that to say is like they do a lot. There's a lot that goes on in a plan. And I think the second thing I'd add to that is they're operating in a highly regulated industry. And so they are very much under scrutiny. They have to perform at very high levels, some of which Robin covered in terms of the quality. But frankly, just from a compliance standpoint, it's very tough. So this kind of gets me to my last point, which is, MCOs have limited resources. And I know sometimes it can be easy to look at a large health plan and say, oh, they've got all the resources in the world. But when you kind of take into context all of the work that they are mandated to do, they really have limited resources. And I think a good example of this is just to talk about the care coordination sort of arm of a managed care plan. Managed care plan, those care coordinators, they're typically reaching about 2 to 5% of an entire plan's population. So they cannot, and I think both Robins have kind of hit this, they can't do it alone. And so they are looking for partners. They really need help because they know that on their own, if they're only ever going to reach 2, 5, call it 10% of their plan's population, they're not going to be able to effectively manage that care, right? So that's kind of, the context of MCOs. Talking about, the experience that MCOs have had with CBOs, with social care organizations, as SDOH has come to the front of the conversation, the MCOs have absolutely dipped their toe in this space. Some of you on this Zoom may have had experiences partnering or attempting to partner. This has been really culturally difficult for plans. As you all probably know, and perhaps have been on the receiving end, plans have typically engaged with social care organizations and CBOs in a very grantor-grantee relationship. The move from that to a contracting relationship has been very difficult. So if you felt that that's difficult for you, just know that you are not alone. That has been difficult for everyone. It truly is, it's a cultural change that has been difficult. We have talked to a lot of plans, talked to a lot of CBOs, and they say, it's sort of like been rocky at best. So again, don't worry, that's not just you, that's just us sort of leaning into this new field. One of the biggest things that plans always talk about is the difficulty in documenting the return on investment of these interventions. And that's not, and I want to be really clear because folks have always been very clear with me, that's not in a philosophical manner. They understand that, delivering a warm meal, housing someone temporarily, all of these services, they understand that. It's that it's in the measures and in the applicability to the healthcare outcomes that they care about. That ROI has been very hard to document. So all of that to say, how does that set us up for this conversation? Social networks are a really interesting approach and one that we think have a lot of potential here. You've seen other places geographically go down this road. I'd point you to North Carolina, especially if you want to kind of get out of New York State for a second and kind of take a look around and see what's happening elsewhere. And I think the reason it works so well is plans need to, unlike the proverb, mile wide, inch deep, they need to be both a mile wide and a mile deep, right? And so a social network provides the opportunity to be a mile wide, having lots of different providers in a network, but also a mile deep so that if they have very specific subpopulations, they know that they're able to deploy very intense interventions and not just light. And the last thing I'll say is that I think plans have been burned. They have tried to do this alone. They have tried to go out and even, kind of been very ambitious and say, we're going to contract with, 100 CBOs. They've been burned. I think what they have not realized in the past is the use of an intermediary such as CCN is really important. And without that infrastructure, it's not a road or a bridge, but it is infrastructure, just like our healthcare delivery system has infrastructure. They just can't make it happen. And so I think in some ways, plans getting a little bit burned as this field develops has been good for the proposal that you all are proposing here, the network, because they've experienced failure. And so they understand that there needs to be an intermediary. So happy to take questions when the time comes, but that's what I would say from an NCO perspective.
Thank you for that, Juliette. So the last panelist, the question is, why does Care Compass Network want to take the lead in forming a social care network? Mark?
Thanks, Lenore. Great to see a lot of you today as well. I haven't seen some of you in quite a while. And happy to answer that question. And part of it, I'll go a little bit down memory lane about, where did Care Compass Network come from? And if you go back in time to where it came out of an assessment that New York State did through the MRT team that identified Medicaid statewide as having high cost and low quality. And so some of the opening remarks that you were hearing, Care Compass came out to specifically target through the DSRIP waiver initiatives and objectives to target those two fronts. That there were measures that we were accountable for statewide spend. We're also accountable on different measures. And in that, Care Compass was specifically designed to be an aggregator for a broader region. And in that role served as the liaison between New York State and the community. So Care Compass Network, it wasn't a singular company. It was a representation of all organizations that served and provided services to Medicaid members across the Southern tier. And in that role, what's very interesting is Care Compass Network, the collective, was held accountable as a broader group for clinical measures. And so as a partner, you may not individually have felt that, but Care Compass Network had to learn those competencies of how to track and monitor and measure scores by partners, a lot of it through trial and error, a lot of it through experimentation and innovation. But by and large, and I haven't browsed the full audience on the call here today, but the organizations that we worked with weren't new, that formed in the last 1 or 2 years. There may be a few of them, but most of them have been in the community for a number of years or even decades. But it was Care Compass Network coming in and providing some of that organization and the moments of collaboration that we've had the chance to do over these past few years that got the results and got the organization piece together that was lacking. And Robin Kinslow-Evans, from one perspective, acknowledges the difficulty in organizing that and the need to organize that. And Robin Cotter overviewed a lot of the direct services, but didn't mention a pop health team with data scientists. There's a service delivery piece. And so there's this infrastructure that was needed and that's been described. And in a way, that's exactly what we had to do over the course of the DSRIP waiver. And so as we've been leaving the DSRIP waiver, as we've been looking at the future, reading the tea leaves, reading all the different roadmaps and things that are out there, this was a specific domain that we said, it's not just one that we've been built and equipped to do and have served this role in a chamber, or the chamber with the DSRIP program, but we really see a deficit in it not being in the community today. And to build on something that Robin Cotter said, it's not a theory that we think this will work and we'd like to try it out. I'll share with you some of our stats and figures. We've already tried out the ability to bring together the community on targeted objectives. And I grabbed one of our end of DSRIP reports, and we had improved over that 5-year waiver, potentially preventable readmissions by 12%. We had increased screening for clinical depression, 28,000 screens annually at the start of the program. And when we ended, they were up to 214,000 annually. Improved mental health follow-up for 7 and 30 days were improved by 20% and 15% respectively. So some of those things where we talk about improving health and wellness and providing social services and social determinants of health and tracking it to the clinical outcome, we've seen the improvement on the clinical outcome side. And some of the latter programs that we started to do, many of you are familiar with the cohort program. It's not finished, it's always a work in progress, but we did start to track and monitor the social determinants of health provided by the community-based organizations. And how do we tether that and measure that against the clinical improvement? We've seen the clinical improvement, but how much of that was from the social determinant of health? And we've seen through the cohort program, several of them highly, highly integrated and successful. And so there's going to be a presentation later here on a new pilot program that we had just recently approved that we're starting to roll out, and we're taking it to the next step. And so you're going to start to see more initiatives from Care Compass Network that really start to laser focus and target in on this. So the last thing I'll say is, and maybe it's not so much the why, maybe I've covered that, but kind of the how is it's a very targeted and tailored approach. It's not a one-size-fits-all program that comes out and we'll just sort of implement across the region. A lot of this is creative thinking. A lot of this is continued innovation. A lot of this is finding the right organizations that serve common populations and really getting that into the weeds and having that integrative support. So that's sort of in the heart of a lot of the programs and initiatives and plans that we have underway. And you're going to hear more about that later. So to Robin and Juliette, thank you for those, your remarks as well. Very, very inspiring from your perspectives. And Lenore, I'll hand back to you.
We have time built into the agenda to answer any questions you might have for the panelists. I'm not at the moment seeing any hands raised or questions in the chat room. So let me pose another question. If an organization that's listening to this presentation wants to become a part of this social care network, what would they have to put in place and how would they go about becoming a part of this social care network? Whoever would like.
I'll jump in on
I mean,
that
Robin
one.
Cotter could maybe address what a community-based organization could do within their organization to prepare for this. And Mark, you could certainly discuss as the lead agency what you would want the organizations to do. So either of you, Mark, go ahead.
Certainly. So we're actually lead up question. We have a conversation coming up on something called the open network. And so we wanted to make it as easy as possible for organizations to reach out and start to ask the questions to even understand what does the social network mean? What are the requirements? How could I get involved? And so the first step is to engage in the open network. And in doing so, low level, minimal expectation from the partner. It's really about how CCN can support you and start to answer those questions. So we've designed an easy avenue for partners to come in and engage and even start to receive some support with the infrastructure and training and different things to equip them to be in the social network, because some might want to experiment and some might want to dive right in. So the open network provides that glide path regardless of where your individual organization is on the readiness spectrum.
And you're right, further in the agenda, people will be hearing more about that open network so they can understand how that's the entry point for becoming part of a social care network. Robin, either of you might address how you need to prepare your organization or what obstacles your organizations might face in trying to join a social care network.
I'll take a shot at that, Lenore, and then ask Robin to follow, because the areas in our experience, whether it was in the cohort program or in embedding community-based organizations into our practice, have been in the area of reliability. And that I'm not trying to say that CBOs are unreliable, but Robin, you addressed in your remarks the workforce issues. And when you're taking a contract at risk, meaning that you're going to have to pay the payer money if you fail to achieve your outcomes, and your partner cannot consistently deliver on what's needed in order to achieve that, that becomes a fundamental problem in the relationship or the partnership. So how do CBOs come together to assure consistent reliability of service and care when they are small in nature and the contracts are large in nature? And I think that is one of the chief things about why this can't be solved on a CBO by CBO basis. It really does require this network, and it can't be a happy accident network. It really has to be intentional. It has to be designed and everybody has to play a part in helping us make it successful. So that would be one of my things that, among many, that we have to look at in forming a social care network.
Yeah, I agree. I think that when Lenore first posed this question, in my mind, I thought initially we need to approach this through our interagency council that we have in our county, but it's much bigger than that. You know, we're a rural county, so we have to look at partnerships, and we can't do this on our own. And I think that's one of the things that we found when we did some of the cohort stuff. You know, looking back at the data, how can we engage other partners and really address this? So I guess more to come, right? Just tune into Care Compass Network, you know, and see where we're moving forward.
I have had some questions come to the chat room. It's acknowledged that Catholic Charities of Chenango County does great work, and you're a Tier 2 CBO. So the question is, what will the specific role of Tier 1 CBOs be in the performance network or in a social care network? Will there really be any differentiation for interactions with a Tier 1 or a Tier 2 CBO?
I'll take an effort at that one. So the relevancy of Tier 1 and Tier 2 and these things has to do with requirements that New York State has put on between the MCOs and the at-risk contract holder, I'll call it. Specifically that there's some requirement, and there's an initial phase, maybe it'll evolve, that there be Tier 1 CBO engagement. Especially I'll refer to the tangible, which is our pilot program, which Dawn will be giving the update on. I'd say that there's not a big differentiator necessarily, unless there's a big need from the at-risk contract holder, because in that program, it's about providing services to meet specific measures. So on that domain, it's about what is your organization competency, where are your skill sets, what regions do you serve? And how does that support the at-risk contract holder? So initially, there's not a requirement, or we have a quota, or things along that line. But those may come up over time depending on the requirements that the at-risk contract holder is in.
Well,
Yeah, and
oh, go ahead, Juliette.
I would just add that while the requirement does still stand, Pamela, to answer your question, of having a Tier 1 CBO in a level 2 or higher contract. It is the, I kind of refer to it, it is the floor, it is not the ceiling, right? And I've negotiated a number of contracts where there are multiple CBOs who are delivering several different services for several different subpopulations in a contract. The state requires one, right? So it's your floor, but you can always build upon that. You can have subcontractors, you can have different people doing different things. So think of it absolutely as a requirement as you're thinking about Bbep and the contracts they're in, but it's a floor, not a ceiling.
So I take it from both your comments, really there's plenty of room for a CBO, whether they're Tier 1, Tier 2, whatever they are, and they shouldn't be so focused on the contracting mechanics. That's something that Care Compass Network can oversee to ensure that the contracts meet both the regulatory requirements and the needs of partners and the payers to form a network that really serves the patient. Another question that Emma posed in the chat room to everybody has to do with the nonprofit finance funding. She said a recent report came out that contracts between CBO networks and healthcare organizations have more disadvantages than benefits due to a misalignment of priorities. And I think the misalignment of priorities sort of gets to possibly the heart of my questions about how difficult will it be in our region to create a social care network, to work together collectively and engage in contracts with managed care organizations to have an effective social care network. Would any of you like to address how we can overcome the kind of obstacles that were presented in this report that Emma is referencing?
Yeah, I think those are critical obstacles and not ones that we would be immune to. So the idea that a layer of infrastructure, as we've described it, that's seeking to organize social services and integrate them with clinical, a success factor number one would be an improvement in health and wellness. And the other, not and or the other success factor would be that it lowers net cost to the system. And if it's not able to do that, then the judge and jury would say that it's an unnecessary layer. It's more philanthropic. So that is something when we say, when you get into the social network or performance contracts, it means that there's a performance expectation. So it is a far different cry from a grant and that relationship. And maybe that's what Juliette was referring to earlier. There's a big difference between making a grant or a holistic program available to everybody in their whole region, which is what Care Compass Network did with the district program. It was everybody gets to do this program. But when you want to get into sustainability and performance level activities, there are measures that we have to track and monitor, and cost is one of them. So I would say, I don't know, Emma, I'm not aware specifically of the region. I can research that of where that report came out from, but I'm not surprised to see the report come to that conclusion that if the cost measures were not met, that it would, sort of refer that into a negative light, because we would assume the same thing if that was the outcome here.
Yeah, Mark, I
Yeah,
would just add.
Oh, go ahead.
I would just add to that the intent here is to access more of the premium dollars. So in other words, to bring more money into the provider segment of delivering integrated care. So it's not just about controlling utilization and lowering cost. It's also bringing more premium dollar to be distributed so that we can pay for social care. And I think if you go back to 2010 and the advent and the genesis of healthcare reform, the operative assumption was that we were spending more money, getting less results in our measured healthcare quality. And the idea was to bring care coordination to the forefront, integrate with community-based organizations, and not spend one other dollar. Well, how is that done? And the only way it's done is if hospital systems can perform better, less discharges, less days in the hospital, less utilization of the ED. And we can't do that without integrating with the CBOs. So that you've got to bring the premium dollars, more of the premium dollar that's collected, into play with those providing the care. And at the same time, you've got to be much more efficient as a system to make the economic principles behind this work.
I'd also add that I do know this report very well. Emma, it's a great question. I actually worked on a project that was part of the cohort that NFF looked at. I think NFF is a tremendous organization, and they jumped right in with 2 feet. They had a cohort of networks. They were not all SDOH focused. I think that's one important thing. And I'd encourage everyone to go read the report. I think it's fantastic. It has a lot of nuggets in there that I think, to Mark's point, we should pull through and learn from. We worked specifically for a network that was looking at doing healthcare and non-specifically clinical services. What I would say to it in general is that, again, I think there are lessons learned. What was interesting to me about it was that I think it was some of the networks that they looked at, they were really in the early days. And this is a recent report, so I'm not trying to tell you like that was 10 years ago, today is different. This is a nascent field, and there is still a lot to be learned. I think when this particular network that I was involved in, they defined themselves very narrowly. And one key thing that they failed to do, which I would commend the CCN leadership for not doing, is they failed to go and listen to the needs of providers, whether it was providers, health systems, or health insurance companies. So they kind of like created a network. They decided people are really going to want this set of services. And then they spent a lot of time figuring out what that would look like. And then when they went to proverbially sell it, the seller was like, thanks for being here, but like that doesn't meet our needs. And so I think one big lesson learned is like we need to reverse engineer, right? Like Robin and the MCOs that we've been talking to, we need to really understand their pain points. We need to really use data to drive the kinds of interventions. And we need to make sure that the interventions and the networks that get formed are built off of that and not built in a bubble of, you know, I think this is a really great idea and maybe people will want this. So all of that to say, I think lots of lessons learned in there, but having been a part of it, I think there's some easy things that that we learned and that we can take away from and make sure not to replicate.
Thank you for those comments. Sally has shared the link to that report in the chat box for anyone who wants to delve into it more closely with the idea of what are the things that they identified as obstacles that we, as we build our social care network, can address at the front so we don't fall into those same traps. I see that Sharon Chesna has raised her hand. So Sharon, if you would like to jump into the conversation here.
Thank you, Lenore. Thank you all for your insight on this topic. It still is, you know, sort of a puzzling topic for a lot of us. So Robin Kinslow, you mentioned as you were starting off the conversation, you know, about, you know, the hospitals sort of really not wanting to, you know, contract with lots of different CBOs, and therefore the network is an advantage. And I look at it and I think about that in context to like our cohort projects. The cohorts were sort of formed together very specifically for, you know, a particular initiative and sort of invited or tagged the partners within that cohort. If you think about this very broad, you know, social network, and let's say CCN then brings everyone in and it becomes the performance network, but there's more than one entity that does sort of the same type of work. You know, who makes a decision as to which of those entities are really the ones that you want to work with? Is it something that, you know, CCN makes a decision on? Does the hospital, you know, get to pick and choose? So that's sort of like the first part of my question. And then turning it around, and I think somebody's already put in the chat, you know, how do you compensate it? And again, where we've had a lot of conversations about, you know, each of us as CBOs need to sort of understand what our real cost is versus getting a prescribed rate. And my fear, you know, all along has been that where the reimbursements that we got as a part of a cohort were one set by CCN and in some respects, possibly, I think, a little more generous than what an MCO is going to do. Now we layer in if the network is being contracted to the hospital then has to think about how they negotiate that into the rates that they're receiving, particularly if it's that PMPM, you know, from an MCO.
Okay, so I'm pulling two things out of that. One is, you know, who makes decisions? How is this network going to be run? And I guess my answer to that really would be to turn to Mark ultimately. But it seems to me, Sharon, that it would run similar to the way we've been running in a joint governance model. So the network has to be, that's what I mean about it being too complex for us to just amp up the cohort program and say we have the infrastructure available to manage a network, because there are many more decisions that are in flux that are subject to negotiation that go on when you're dealing with a large payer group. Like our Medicaid payer population under contract is 8,000 members, not 200. And so 200, it's easy to see through and easy to make decisions. In a large payer agreement, not so easy. And that whole piece of what parts of the social care network come to play in a given contract, I think needs the administration, management, and decision-making structure that comes with having a formal network. I think there's a more robust answer to that question, and we probably should set up a time in one of our stakeholder meetings or strategic planning meetings to really probe that. But I think that's what part of what a network brings is governance and decision making, that health systems are not going to have the ability to really do, that the network has to do for itself. So that, I believe, lies with the network. The second thing, when you were talking about how to incorporate compensation, as far as how I've been thinking about this is how do we get started with it? I've been looking at the dollars that are currently in play in our value-based agreements, and in specifically, how many of those dollars are left on the table because we can't perform without some kind of social care network assisting us in that performance. And so part of getting the money into the network, in my opinion, is about our ability to negotiate more on more risk, which means we have to have confidence in what we do, so that we're bringing more premium dollars to the table to fund or to pay for the care that comes through the social care network. We need to save dollars on utilization to shift them into that network, but we also need to bring in premium dollars to help pay for that network. And compensation, again, would be determined in a negotiation between the social care network and the given health system provider. Or if we're going to think bigger, a regional clinically integrated network. So I think some of those answers require really getting down into the weeds on how payment occurs, how negotiations occur, and getting more transparency around that without violating antitrust. If anyone else wants to try this question, I'm opening it up.
Yeah, I know
Well,
we're at time. I would just
right.
add quickly on this one that in the past, what we've done is deployed initiatives to partners on the basis of what we were trying to accomplish. And so part of that is hard to answer until we know what specifically the health system in this case would be trying to address. We've done things like the innovation program, which we were trying to get innovation from all partners. So it was an open invite to each and every partner. We did things like the MIP program, the Metric Incentive Payment Program, where we wanted to target a specific behavioral health measure, and we sent that on an RFP to all of the behavioral health partners. So there's different things that you could do, and we've seen success with some of them, and we could probably deploy them. But I agree with Robin; it would be a standardized process and shared governance and all those sorts of things.
We are at the end of our allocated time, so let me say two things. First, there are questions that are coming into the chat. We've addressed one now about a little discussion about financing. There's another about should CCN set the parameters for CBO and then take all comers. The answer at this point is clear that this meeting today is an introduction to this whole concept of a social care network. And there's obviously a lot to do for us to fully develop this and work collaboratively to the benefit of the patients and people across our region to help improve both individual and community health. So more to follow, and stay tuned for those updates and become involved in answering the questions that are being posed today. The second thing I'll say is that any questions and comments, you can continue putting them in the chat. And at the end of the presentation over the next few days or weeks, that Care Compass Network will put together responses so we will all be able to hear about what was said. Finally, before we move on to our next program item, I want to point out that at the end of each presentation, we ask people to complete a Survey Monkey, giving us feedback about how the overall presentation went. If you happen to have to leave early today, the link has been provided in the chat room, so do please fill that out. As I said, this is a really important meeting with a lot of updates, so I hope you'll all be able to squeeze in a little additional time to stay to the end of the program. So let us move on to the next topic and have Dawn Scully, the Director of Project Management at Care Compass Network, provide an update for the Care Compass Network Social Impact Pilot program that is getting underway. So Dawn, oh, and let me say, I forgot to thank all the panelists for their input and willingness to share their perspectives. So thank you, everybody. Now, Dawn, please.
Thank you, Lenore, and thank you to the panelists for sharing your perspective. As each of the panel members indicated, there's a growing interest for social care networks. And as Mark mentioned earlier in the discussion, CCN has a program that we put together, our CCN Social Impact Pilot Program, which is an opportunity for us to pilot and gather data for how social care networks can assist lead VBP contractors in closing gap in care metrics and ultimately improving the care that community members receive. This is an important social impact investment initiative for many reasons that you'll see throughout this presentation. With my presentation, I'll give you an update on where we are and try to proactively answer questions that are being asked. Next slide, please. So we have approval for $4 million to implement the Social Impact Pilot Program. The goals of the program are: 1, to improve gaps in care, to enhance patient outcomes and quality, to innovate and perform utilizing CCN funding, district dollars in some cases, to excel in VBP contracting, and to support lead VBP contractors to increase capture of shared savings in their existing performance contracts. Next slide, please. So recognizing some of you on this Zoom may not be familiar with the program, I've included a summary of key steps. So CCN will work with lead VBP contractors to identify VBP shared savings and other opportunities in the existing performance contracts that they have. If we agree that there's opportunity to collaborate on metrics, CCN will form and operate a social care network to help support that lead VBP contractor. And Pam, from your question earlier, this isn't specific to a CBO tier 1, 2, or 3. It would really be based upon the services and the interventions that we would need the social care network to provide to support the metrics that the lead VBP contractor is aiming to improve. There'd be downstream network partners. The partners in that social care network would receive funding from CCN to support the pilot interventions that we select and need to help improve those metrics. And then lastly, the goal is to have revenue earned from contract performance in the end. And so let's think about and walk through an example. Think about, previous slide, please, you could stay. Think about a measure such as the comprehensive diabetes care and eye exam, for example. Having an eye exam by an optometrist or ophthalmologist in what may be yet another location that a community member has to travel to in order to receive that eye exam, it can be challenging. So think about what a social care network of CBOs could do to help close gaps in that measure. You think about things such as helping the member find a location that supports their insurance and arranging transportation to that location, maybe arranging and providing childcare services for the member's family, including the cost of those services where it may not be covered. Even go so far to maybe check in the day before and make sure they're all set and ready to go and that they're still on target to attend that appointment. With the Social Impact Pilot Program that we're building right now, those services would be provided and compensated for by CCN to the downstream partners in that network. And we could help we'd be collecting data to inform the successful interventions related to the different metrics that were being worked on within that network. So we'll be able to, at the end of the program, we'll be able to link interventions or identify interventions that work and actually help improve outcomes and those that may not. So that's a main goal of this program overall. One question that keeps coming up from partners is the funds flow and what would that look like to downstream providers? I think Mark alluded to earlier, this is different from previous programs where it's really not a one size fits all. We're developing our funds flow model currently for the pilot program, but one of the main important details with this is what metrics will that network be working on, and for how many community members for those metrics. So that's a critical factor that goes into this. So we're not at a point yet to share what that looks like. And so the details of funds flow will, within each network, will be tailored based on the metrics to be impacted and the size of the target population for each. Another question is how many partners, how many organizations per social care network supporting a lead BBP contractor? Again, this depends on the number of metrics and the population that we're trying to impact. But you do think about with the cohort management program, and Robin alluded to this earlier, there was a max limitation of 200 200 Medicaid members for each network. And this will be much bigger than that. So, you think about, probably an average of, maybe 4 CBOs per network, but it really depends on the focus of what we're trying to do, the metrics and the targeted or the target population for that social care network. So given that though, we have heard feedback from partners that, there's a need to have upfront funding to really help build capacity to be able to support these networks that we're building for this program. And as we build out our funds flow model, we'll be sure to consider the need to support capacity and what may be involved with that. Next slide, please. So the current status of this program is we have been meeting with lead BBP contractors in the 9-county region that CCN supports, the Southern Tier region. We have 3 non-disclosure agreements executed and are further discussing gaps in care in current performance contracts with those 3 organizations. And with an additional, we have an additional an NDA in process with a 4th organization. So, but due to the confidentiality of all these discussions, there's not a lot that can be shared. But I think what this does is it begins to give you an idea of scope of this program. With an average of maybe 4 CBOs per network and potential for maybe 9 networks, that totals to about 36 CBOs to be engaged, but recognizing there could be overlap within the networks potentially, again, depending on the services and the interventions and the region that would be supporting. This just begins to provide you an idea of availability to participate in the program. Next slide, please. So this is a timeline. It gives you an idea of the duration of the entire program. We've broken it into 4 phases and have listed high-level deliverables within each phase that CCN is working on. And there is overlap between phases. Currently we're in the initiating phase, the very first part of it, where we're trying to understand the opportunities with the metrics, and we're building our data strategy and our funds flow methodology. But when we get agreement to move forward with and collaborate with a lead BBP contractor, we'll begin to start forming what that network would look like. We would know and have identified the metrics and the potential interventions by then, and we could move forward to start creating that network and start making sure that they're in a position to be successful to deliver those services and to collect the necessary data that we're looking for this program. So that, obviously this is a very, very aggressive timeline. Most of the performance contracts that are out there begin on January 1st of the calendar year. So our goal is to have these networks up and running by January 1st so that we could begin making direct or providing those services and interventions and begin monitoring performance to see what we may need to change, how it's going, what do we need to do differently. So, and then lastly, of course, we'll summarize the results at the end and do an overall program evaluation. You can see that if we are going to start January 1st to begin providing services to these members or social care services to these members as part of this program, we'll need to be very aggressive in creating those networks and doing all of the work that we need to between now and then to be ready to go. So currently we're developing the material and the infrastructure internally to be able to do that. Next slide, please. So this is my last slide for the presentation. Once we have agreement to move forward and we know what metrics we're going to be working on, and the number of community members involved for each metric, we're planning to utilize an RFA process for CBOs to be considered to participate in the network. We recognize that community-based organizations are all at different stages of readiness and interest to participate in this type of network, hence why we're looking to use the RFA process. We would identify the interventions, and we would be looking for the network to respond to that and have, indicate their interest to apply, and then they would submit their application to be considered. We, of course, would also include the regional areas or counties that we'd be asking for that support of. I'm sure there'll be more to that, but that's the general gist of it for right now. You can expect that, we could be rolling this out as early as the end of this month and possibly going into November at the latest, I foresee. So, with the completion of, at the end of this program, the goal again would be to have data to connect interventions to outcomes and be able to further demonstrate the value and impact of a social care network. So at this point, that completes my presentation. Later on, you'll hear from Lisa Berard on how CCN can support partner organizations involved with the social care network. So that's coming shortly. And at this point, thank you for allowing me to share an update. Lenore, I'll turn it back over to you.
Great, thank you. If people have questions about this program, I don't know what's wrong with my speaker. I hope I don't sound muddled to people. I do to myself. But anyway, if people have questions, they can direct them specifically to you, or they can put them in the chat, and Care Compass Network will direct those questions specifically to you. So the next item on our agenda is the Spinal Care Project, a presentation by Dr. Brian Justice, who's the Spinal Program Medical Director for Excellis. This is particularly timely and relates to the challenges that we currently face with the opioid epidemic, which was both exacerbated during the pandemic, and also spinal care and addiction to narcotics are intricately linked. So Dr. Justice, I turn the program over to you, please.
Thank you, Lenore, and thank you, everyone. Yes, I'm going to talk about spine pain a little bit, but it's really kind of a secret backdoor to talk about community health. Next slide, please. So we're going to review just some of the current challenges in healthcare that create the infrastructure of how we developed our spine health program, but how the spine health program may be a nice springboard into community-based health that could impact a lot of our chronic diseases and overall well-being within our community. So I'm going to try to, create a bit of a compelling vision for you why we're experimenting with this and piloting this in Binghamton right now, and what next steps might be, all in 10 minutes. So hang on to your hat. We're going to talk fast. Let's go next slide, please. So I do want to talk about two twins, Bob and Gary. They're hypothetically identical twins who hypothetically have the exact same back pain on the same day. Bob is in a very typical system where he has back pain, does his homework, goes into his doctor, demands an MRI, an opioid, and see a surgeon. Make a long story short, these are three things are predictors of who with acute back pain could become chronic. And then Bob goes, sits home, waits for his MRI, sees scary language. Work doesn't allow him any light duty. They only want him when he's back 100%. To make a long story short, the system is creating an environment that's turning Bob's acute back pain into something chronic. And this is a real eye-opener that the literature is just really now supporting very clearly. And it's something that we need to address as a community, as compared to Gary, his twin brother, who, if he goes to a pathway adherent doctor who gives him a meaningful, concise history, functional examination, clear diagnosis, engages him in his own recovery, and there are community-based support of both education and return to work options, all of a sudden that exact same episode of back pain could be over within days or a week or two versus possibly never with Bob. Next slide, please. So we as communities are creating these dysfunctional care vortexes, and I don't mean to pile this on just the providers, though that's a lot of what our training is, but employer groups, payers like Excellis, we all play a role in this, and we have to be aware of what we can do so that we can create a more supportive healthcare system, which is really going to come out of community. Next slide, please. So you folks more than most know this data and know that what influences health, the healthy behavior and environment, which is really that 70% are those social determinants of health that we've been hearing. What decisions does the individual make, and do they have the infrastructure to follow through on those healthier decisions? Yet where's our spend in healthcare today? It's almost all on the care within institutions themselves, which doesn't have as big an impact as we'd like to think it does. How do we make that shift? Next slide. Thank you. And then also, there's a responsibility for health issue. This is from University of Utah, where they look by stakeholder, ask some basic questions. Who's primarily responsible for health improving? When they asked patients that, about 45% of the time, they said, I'm responsible. 44% of the time, my doctor's responsible. Well, ideally, I think we would like to create an environment where everyone takes personal responsibility for their own health, and they look to the healthcare system to help them, guide them, but not to abdicate the health to the system itself. Even more, a bit unsettling to me is when we looked at the physician's response to this, where 75% of them said that they thought they were responsible for health improving. Now, no wonder there's so much provider burnout. No wonder there's unilateral decision-making, and no wonder that there is maybe defensive medicine going on when you have that perspective. Next slide, please. Other cultural issues, and Lenore just mentioned opioid use, but why in the world are we 30 times more likely to die from a drug-induced death in the United States and Portugal? This is a cultural issue. This is not some epidemic that we have that Portugal doesn't. Next slide, please. And why in the world do we have 25% more American adults think they're in pain now than just 17, 18 years ago? Why is one of the reasons is we started this pain is the fifth vital sign component and really got everyone's focus on pain. And by overly focusing on pain, it creates pain, which is what that second study indicates. It creates a hypervigilance. Next slide, please. So, one of the key initiatives that I want to bring forward when it comes to back pain and using that as a springboard to overall health is this idea of we have really a significant passive healthcare system. And I thought this study really brought it out. This is the Journal of the American Health Association, where they were surveying a study where they surveyed 40,000 adults. And during the course of that 4-year survey, 8,800 of them were started on either antihypertensives or lipid-lowering meds. And lo and behold, what happened? Those who were started on the meds compared to the rest of the group in the study, their BMI actually increased and their physical activity declined. So think about that for a second, right? That's the exact opposite of what we would want to happen there. And so, again, I think this is an example of the individual abdicating the responsibility of health to the pill. And by doing so, actually creating an environment where other comorbidities are going to worsen. Yet, if this is our only health indicator we're looking at, we might be patting ourselves on the back to saying we're doing a good job because we're not looking at the person holistically. Next slide, please. So, we need to counter this passive care culture. We need to engage patients. We need to really ask some questions. Does this individual need to become a patient? And how do we help them self-triage? With back pain, that's especially true. Most of the time you don't, but sometimes you do. Where do I go? Who should I see? How can our systems create an environment where the body can heal so it's not dependent on a health system just to unilaterally heal the patient? And how do we get our patients and our providers and our employers and systems to understand that a pill, a procedure, a surgery should never be administered in isolation, that always accompanied by something supportive action that the patient does. The patient needs to feel that they are engaged and that they have some control of their own health. Next slide, please. We're using back pain as a springboard because it's so common. If you haven't had a significant episode of back pain, I have bad news for you. You probably will. 85%, 84% lifetime prevalence. That's just back pain. Neck pain is another 30 to 60%. 25% are going to have some significant pain in the next 3 months. And yes, it is still the leading gateway into opioid use. Next slide, please. So there's really no other area in healthcare that has had such increase in costs, really even outspending the rest of healthcare, but more disability coming out. We have a very inefficient spine care system in the United States. High variation, which is that chart on the right, that happens to be surgeons. But the reality is, if you have back pain and you see 3 surgeons and 3 pain interventionists and 3 physical therapists and 3 chiropractors and 3 primary care docs, you're probably going to hear different things from all of them. That's how inconsistent the care is. And when there's that level of variation, there's confusion. And the shopping the grocery store picture is a study that compared back pain to going to the grocery store, meaning that they identified 120 different treatment options and 24 different provider groups that supply those options. And here's high variation between those providers. So no wonder there's so much confusion, and no wonder there's so much wasted spend and needless human suffering because of inefficiencies. Next slide, please. So, this doctor shopping is very common. When we were working with the University of Stanford, this is their slide, we use permission, but we're trying to expedite that and create pathways where the evidence and technology and the data are all streamlined and patients have access to this care pathway where there's less variation of care, which is going to lead to higher quality and lower cost, better value for our communities. Next slide. Thank you. And so the challenge for all of us is, who's going to translate this data and this evidence into meaningful action? And I'd like to propose that it should come from the communities, that the community data, how do we bring that and how do we translate and form that into a meaningful story and conversation that key stakeholders can relate to so that there's action that impacts the quality of our communities. Next slide, please. So our program, I've identified the problem quickly. The solutions you can see there, but this idea of passive to active is, people think of back pain as a disease. And if you think it's a disease, then you're looking for a cure, and it isn't. It's a part of life and it needs to be managed. And management needs to come from you taking responsibility for your health and the system being there to support you. And our Spark program has created the advantages you see on the right-hand side. This is really not a talk so much about our spine program, about the community potential of using it as an infrastructure. Next slide, please. But we do some trainings in the program, 2-hour primary care, it's actually just down to 9 minutes now, 12-hour for any other willing provider to do the full care pathway. We've shown significant downstream savings from doing that, and we publish them in peer-reviewed journals like the Journal of General Internal Medicine. The stakeholders that we engage, patients, providers, employers, and plans, are really important for us to understand all of their perspectives and bring those forward, not just to meet their needs, but to engage them in the solution. And so the benefits of this type of program is to support the community. And we've created this common language and common toolbox so that the message is consistent to the people in the community. So they're not, hearing from some website or their next door neighbor that, gee, you should get an MRI for that, when it's inappropriate to get one, which can create fear and anxiety from the scary languages within it. Next slide, please. This is my street cred slide, just to say that, as I'm pitching this idea of spine as a public health springboard, you've got to believe in the program. And we have vetted this program nationally for the last 10 years. I won't go into too much detail, but it has been adopted and adapted, and we have supported spine programs at Stanford and Dartmouth and University of Pittsburgh, University of California. San Francisco actually put in their journal article that they developed their program around this program. Duke University is just engaging us right now. The European Spine Journal looked at all the spine programs in the world. The only US program that they picked that was really evidence-based and patient-centered and implementable was our program, Consumer Reports. Their last issue on back pain, the only program in the country that highlighted was ours. So we've really been vetting this hard across the country. So I want to make you confident that the infrastructure is there, but what can we do as a community to really build on that is key. Next slide, please. So one of the things that we've been working on for years now, actually started with Consumer Reports, is to build a patient decision guide app to help an individual. When does a person need to become a patient? If I have back pain, how do I self-triage? Do I need care? And if I need care, can it be self-care? And if it's not self-care, how do I go through the system in an efficient and effective way? And what questions should I ask? And what kind of provider should I see? But still maintain their ability of choice. And then as they manage that, the real secret sauce of this program, of this app, and why it ties into community health so well is that the things that treat back pain and the things that prevent back pain are things like, of activity and exercise and good posture, but it's also things like eating more vegetables and anti-inflammatory diets and being more mindful to manage your pain, getting a good night's sleep, quitting smoking, losing weight. All of those things impact back pain, and lo and behold, they impact many of our chronic diseases. The key also built into this app that we're hoping to have models out there within the next few months is to collect data, especially patient-reported outcome measures. We think those are really important. As we talked about the health indicators, we don't want to just measure things that are easy, like blood chemistries or blood pressure, but also things that are meaningful to individuals that they can relate to and that can be motivating to them. Next slide, please. So all of these, cost drivers are impacted by the same things that I just mentioned about back pain. Next slide, please. So as we start to wrap it up here, the community health is the best approach. Talk about preaching to the choir here. The social determinants are huge, but we have to engage everyone. Now, the employers are certainly engaged in why back pain might be a good springboard here, because it's their number one cost. It's the number one cause of disability in the world, in the United States. Interestingly, for me, as I've gone through my education in this area, and again, you folks know so much better than I, but both the rural and urban folks have the same belief system in that they want care of their community, from their community, by their community, and it needs to emerge from the community. And so that means we have to understand the immediate needs of the community. And I like what Robin Cotter said earlier, when she said very strongly, we know the community. And that's why you folks are so important to a program like this, really working well. Tip O'Neill, for those of you old enough to remember, a rather flamboyant speaker of the House of Representatives, very famously said, all politics is local. I like to paraphrase that and say all health care is local. Next slide, please. So what if all the providers are on the same best evidence care pathway, starting with spine, but hopefully evolving to others? And what if all the stakeholders that we mentioned are supporting a patient-active approach to health? And what if we had a resource app that could actually give better information and actually measure outcomes? What if we could dispel the common myths that are driving inefficient and harmful costs? And then can we use the teachable moment of back pain that would trigger this self-care that could impact not only downstream back pain costs, but also our cost drivers and chronic diseases of the community? Next slide. So, the advantages are pretty, apparent to all of you. But especially one of the things that interests me is this engaging volunteers in the community, which so many of you are so good at. And, the fascinating thing there is just by being a volunteer, you're healthier. We know that it helps on mental health issues, and we know it helps in levels of happiness and overall levels of well-being. Also, I think that these kind of programs now can really bring dollars into the community, because there's research and grant dollars at the national level that are very interested in community-wide data measurement and opioid use, of rebounding from COVID, and addressing community health in new and different ways. Next slide, please. So why are we starting with Binghamton? One is because of CCN. One is because they've been brainstorming this with us for the last couple of years, and interested within your community and within Binghamton. High poverty rate, high level of disability, high level of unemployment, high level of opioid use. COVID has created an environment where your two main health systems have really started collaborating. So I think there's a really intriguing opportunity there. Many of you are not from the Binghamton area. This is just where we're piloting it. But if you're interested in these type of programs, please keep in touch with us, and we'll see how we can bring this to other parts of the state. Next slide, please. So right now we've these are the strategic partners that are involved in this initiative already. And you can see where we're going with them. And those question marks are you folks. Many of you, I think, would really help us to push this initiative and can really add to what we're trying to build here. So please, contact the folks at CCN, and we will be glad to bring you on board to engage on this. Next slide. And my last slide is, I'm so sorry I went through this so quickly, but by coincidence, I'm speaking at the North Country Leadership Summit. I have a whole hour there, and at 10 a.m. next Friday, I'm there. It's free. So if you're intrigued by what I talked about and you want to hear more detail about it, feel free to tie into this. So next slide. So thank you very much. My apologies for being so fast, but I wanted to take you through the journey as quickly as I can and get to the vision part. So thank you for the opportunity to speak and direct your questions. I don't think we have time right now to me or through CNN, however you want to do it. I'm ready if you are.
Thank you, Dr. Justice. Yes, people have the opportunity to contact you. Your email is there on your thank you slide. The slides are available to people, so anything that you breezed over, they can look at the slides and investigate more in depth. We are at the end of our designated time, but there are two additional short presentations that we want to quickly move through. The first one is to the Care Compass Open Network Update by Lisa Berard, the Network Development Specialist. Lisa?
Thank you, Lenore. And in the interest of time, I will try to keep my focus on the most salient points. So I'm happy to be the person presenting to you the announcement of the official launch of our post-DSRIP Open Network. The goals of the Open Network are really to continue our formalized network of partners, maintain that comprehensive foundation, the diversity that's so important to the collaboration and meeting all of the health and social care needs of the community, and also to support and enhance the coordination of integrating care in the CCN region, evaluate and support our partners' ability to participate in a performance network, and to provide a targeted framework and structure for operational support services. Next slide, please. So I think the most important point today for relevant to social care going forward is that the Open Network is the gateway to the Performance Network and any and all of Care Compass Network's collaborative and innovation opportunities going forward. And the very first of those opportunities is the Social Impact Pilot Program that Dawn gave an overview for you earlier. So the Open Network, all partners may participate in. As I said, we want to maintain that diversity of services and social subject matter expertise. And as organizations choose, they may begin to prepare for participation in a performance network focused on closing gaps in healthcare outcomes. Next slide. Some of the network benefits. So you can become part of a stronger, more powerful voice through regional advocacy, have access to the subject matter expertise of our CMO, a workforce development and training to prepare your work staff, not only to do their jobs now, but what that might look like in the future. Grant supports to find focused, targeted opportunities to meet community needs, develop new programs and support existing programs, collaborative opportunities for grants, and also to provide data and support of your grant applications. Compliance support in the form of HIPAA trainings, along with access to a library of policy and procedure templates. Data management to allow for the exchange of care plans seamlessly and, very importantly, securely. And of course, population health support to help translate all of the data into meaningful and/or actionable information. The participation agreement will be required to receive these services effective January 1st of 2022. Next slide. So just a bit about the participation agreement versus the currently existing partnership agreement. The partnership agreement was designed to support the DSRIP initiative. However, with DSRIP having ended, the scope of activities that we can now participate in are broader and can have a greater focus on our regional goals versus those of the New York State Department of Health. Two differences to note from a partner accountability or actionable perspective: there will be an annual declaration with regard to the organization's interest in a performance network, and also an annual validation of an organizational partner profile to ensure that we maintain current and accurate information. Again, this agreement is the gateway to any and all future engagements. The social impact pilot program is already well underway in its design and will be launching shortly. If you do currently have an active DSRIP-based partner agreement with Care Compass Network, you will automatically be sent this new participation agreement to review. And the timeline for that will begin early next week. The turnaround is completely contingent on poor Mark and how quickly he can sign each of them. As soon as he's able to sign your agreement, it will be released to you. Upon execution of this participation agreement, the prior DSRIP-based partner agreement will be terminated, with the small exception of a few number of organizations who do still have project Appendix Cs that are active under those prior contracts. So that noted, those organizations will also need to have the participation agreement in place in order to engage with the future opportunities with Care Compass Network. Next slide. So more information will be forthcoming and made available on the CCN website. We'll also be disseminating a marketing flyer that will have additional information on services. If you have any organizational specific questions or would like to have a conversation with more information, as always, your regional leads and partner relation teams are available for conversations with you. And if your organization does not currently have one of those previously referenced DSRIP-based partner agreements, and you are interested in joining Care Compass Network to avail yourself of the future opportunities, please email the address on the screen and a representative will reach out to have a conversation with you.
All right, thank you, Lisa. All right, so the final presentation is by Mark Ripecki, who will give us a new development, an 1115 waiver that's being proposed. So Mark.
Yeah, thanks, Lenore. And this will be a brief update, and this is the only slide for it. So I'll try to work through this overview. But many of you may have seen, and if not, this will be the announcement that a few weeks ago, back in August, New York State released to CMS a new 1115 waiver. So I wanted to give you an introduction to this and also maybe level set some expectations. I think first and foremost, it's helpful to know that this is not a DSRIP 2.0 waiver. Previously, we saw that come out from New York State, and the DSRIP 2.0 waiver, as we saw it, was an extension of the original DSRIP waiver in New York State. This is an entirely new 1115 waiver. There is a lot of commonality in it from the previous DSRIP 2.0 submission, but there are some key differences. For one, this is a proposed 5-year term with a requested total of $17 billion. There's 4 core focus areas. One of them is building integrated delivery systems. Another one focuses around supportive housing. A third one looks to redesign support for an optimal response for future pandemics and natural disasters. And lastly, statewide digital health and telehealth infrastructure. The means and mechanisms by which those things would be organized and addressed would be through 2 distinct roles. And so this is where there's some similarity from the original DSRIP 2.0 submission. One is a social determinant of health network, and another one is a new role that is called the HERO. It's important, if you saw Governor Hochul's announcement recently about the New York State passing the HEROES Act, that the HEROES Act as related to COVID response for organizations has nothing to do with the hero role that is assigned in this submission. And when I say hero role, I'm thinking of a sandwich, and that's also not what this is supposed to be referring to. This is also draft, and I'll end with that. This is an informal submission of sorts from New York State to CMS. New York State will ultimately have maybe some feedback. I think that's what they're intending to get right now from CMS. And then they would open public comments. So there's not a public comment period right now. Previously, we would grow familiar with New York State doing those sorts of things. So there's that's something that would be coming. We don't know if that would start in a month or in 6 months, but some of these negotiations do take time. We also know that from reading it, it's 35 pages. There's lots of information missing. So it seems like some additional details still need to be crafted out. There's some areas in it that seem very light. So part of this might be their negotiation tactic with CMS. Part of it might be to just get core information and feedback on specific domains. But wanted to just make sure this was on your radar. It's on Care Compass Network's radar. We're going to be watching it. We'll be giving frequent updates to stakeholders. And similar to before, we'll be organizing responses, getting your feedback, helping to organize a public comment on behalf of Care Compass Network, and even identify maybe recommendations to changes when those windows open up. So that's the summary in the report, and we can also get the link for that in the chat, and we'll post that on our website as well.